The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hello, TMD warriors. Welcome. We are gathered here for the next episode of TMD Demystified. I am Tony Urbanek. Today's title and topic involves the concept that I have observed for the past 46 years as an oral and maxillofacial surgeon, for sure. Certainly for the past 12 years, as I've worked through the stages of developing a non-surgical device for the treatment of temporomandibular joint problems. And that concept is this. The consensus is, among universal consensus, among patients and doctors of all varieties and patients of all varieties, that when it comes to, quote, TMJ, nothing works. Nothing can be done about it. Therefore, the topic for today and the title is, as it is, TMD, nothing can be done about it. That's been the consensus. Nothing can be done about it. And I am going to give you the evidence why that is, what I've seen, what I've observed, what everyone else has seen and observed. And then, of course, there is a solution, and I will define that for you in the end, briefly, and tell you why it is a solution. But let's just go through this concept that TMD, nothing can be done about it. That has been a battle, because if the general consensus is nothing can be done about it, when someone comes along and says, no, I disagree, something can be done about it, generally the response is this: I don't want to know. Now, we've talked about skepticism. I did an episode on that. But this episode is going to actually give you the evidence, the examples, what's going on, what I see constantly. And I get to see it because we see just a huge number of patients out of this practice, which is duplicated now by other providers who use our method device throughout the United States, and they observe the same thing with their patients and their colleagues about this thing. Nothing can be done about it. There are a few, I won't call them exceptions, there are a few tails to the bell curve on this concept. And we may reserve that for a different episode. But the evidence for the consensus is multiple. So I have to drag these out. I've dragged them out before, but I haven't put it all together in one episode to make my point. And the point is, yes, there is something to be done about it. But first we have to get past everyone's knowledge with blinders on that nothing can be done about it. The first example of that, and I have a list of 2, 4, 6, 8, 10 items here. And there are more. I just jotted these down. Literally, I jotted this down in preparation for this episode. It took me about 90 seconds, 2 minutes. All right, evidence, nothing can be done about it. The night guard, I've talked on that before, but we know, I can prove, the statistics are in, that half the dentists in the country, if they do anything an attempt to treat TMJ, TMD, their solution will be to give the patient a night guard. Basically, a night guard is not a whole lot different than a athletic guard. A little simpler, a little stouter, maybe. I've used both. But half the dentists give the patient a night guard and tell them that this is your TMD treatment. I had an example of that 1 day ago. Yesterday, Monday, my day to see patients, and the patient came in referred by her dentist. She had obvious symptoms. I won't go through all that. Obvious symptoms, obvious positive findings on physical examination. But before the dentist sent her to me, he gave the patient a night guard and said, here's your TMJ treatment. And when that didn't work, then I guess he finally broke down or had a change in heart, or I have no idea why he started out with a night guard. But a night guard is a night guard. It just covers the surface of the teeth, upper and lower. You can't actually crack a tooth, I don't believe, with a night guard in place. But it actually, most of the time, it makes TMD symptoms worse. And patients tell me that all the time. So half the dentists make a night guard and give it to the patient, either knowing or unknowing it's not going to work, not be effective. For whatever reason you want to make up, they're doing this. I'm not going to comment on that. I have my own opinions. And the other half don't want to see TMJ patients at all. I mean, if you have a patient stumble into a dental practice and the provider doesn't want to see the patient, he just turns them away, say, I don't do that. Or if he knows of someone who he thinks does, we'll send them elsewhere, send the patient elsewhere, and not make a night guard, just do nothing. And that is just the most common thing in the world. I mean, we see hundreds and hundreds and hundreds of patients come in with that kind of history because the provider, in this case, almost usually a general dentist, but can be an orthodontist, can be a pedodontist, can be an oral maxillofacial surgeon. And their opinion is nothing can be done about it. We'll make a night guard or we'll do nothing and send them anywhere elsewhere. Next example are PCPs, which I'm very familiar with. My colleagues who are PCPs, and I hear it all the time. Finally referred in from wherever, and I'm in communication, do a history with the patient, and the patient says, well, I say, who have you seen for this problem, or exactly what have you done for this problem prior? And they will come up with a history similar to, well, I saw my regular doctor, their PCP. I went, and that is like that's what I hear. That's what they call them, regular doctors. Okay, I went to my regular doctor, and he listened to my symptoms, and he said, "Go see your dentist." That's a really good example of sending your patient elsewhere. Makes a couple comments about what the physicians, the general PCPs, think about this. Number one, they know next to nothing, if not anything, nothing about the temporomandibular joint or related symptoms or related disease. Number two, they don't want to know anything about it. They don't want to look it up. They don't want to be part of their treatment services. And that be whole discussion why. When I was in medical school, I was asked by the dean of the medical school to teach, because I was a dentist and an oral surgeon. I was asked to teach my medical class what they needed to know about dentistry, and gave me 1 hour to do it. Oh, you can imagine that was an interesting hour that I gave, but it was, I took it as a compliment and just went on. PCPs not almost, always don't have an answer. Basically, they think nothing can be done about it. Just go see your dentist. Hopefully, he knows something about it. And we already covered what dentists think about this. problem. Half of them don't do anything, don't want to do anything, and half of them make a night guard. Wow, we're going down a list here. And you can see how this problem, TMJ, TMD, is getting nowhere, has gone nowhere, when everyone's conception is you can't do anything about it. Next good example that I see all the time, people go to their convenient care clinics, their walk-in clinics. Give you a couple statistics. I've given them before, but we're kind of pulling this all together in one episode so I can make this point. Convenient care clinics, we now know that more and more and more patients who have a problem of any kind, medical problem they perceive as a medical problem of any kind, prefer to go to a convenient care clinic rather than a PCP or their regular doctor, make an appointment, etc., for various reasons. It's convenient, and patients love convenience. Not knocking it, but they go to their convenient care clinic, who are invariably manned by either nurse practitioners or physician's assistants, and they come in with symptoms. 70% of patients who go to convenient care clinics have symptoms associated with the head and neck, 70%. And 70% of patients who have a problem don't go to their PCP, they go to convenient care clinics. So it's 70% go to convenient care clinics, and of that, 70% have a complaint of something to do with the head and neck, sinus, ears, eyes, mouth, jaw, neck, headaches. Those are the most primary symptoms. And I can tell you that when a patient hits those convenient care clinics, if the nurse practitioner, physician assistant doesn't know anything about TMD, then it's misdiagnosed. If the patient comes in with an earache, which is very common, the nurse practitioner will look in the ear, and whatever it shows, and it's going to be documented almost always, whatever she's looking at, the patient ends up with antibiotics for an ear infection. I have had patients who have actually gone through, the one that sticks out in my mind right now, it gave me a history of seeing 3 separate convenient care clinics because of the ear pain, which turned out to be obviously TMD symptom, among others, the patient had. And the patient was given antibiotic at 3 separate, different convenient care clinics, when finally the patient went to an ENT doctor, and quote, an enlightened ENT doctor here in the Middle Tennessee area, who was familiar with what we do and how we do it, and had been taught how to diagnose TMD, which is quite simple. And that particular ENT took a look in the ear, and he says, there's nothing wrong with your ear. You don't have ear infection. Pushed on the joints, and it hurt. And he said, you have TMJ problems. Go see Dr. Urbanek. And that's how the patient got to see me. But, it's a good example of, without the proper knowledge, the nurse practitioners, physician's assistants who see these patients in the convenient care clinic do whatever they usually do if they think it's an ear infection. But as far as TMJ problems go, if they suspect it, nothing can be done about it unless they're enlightened. And we are now achieving more and more enlightened convenient care clinics here in Middle Tennessee who can actually diagnose temporomandibular joint problems and refer them to the proper place. Next in this order is migraines. Extremely common problem. Headaches, extremely common. By the way, there is no such thing as a normal headache. You may have come to that conclusion yourself. You may have heard that, or this may be news to you, but there's no such thing as a normal headache, even though in history, taking a history of a patient, very commonly, patients will just give you the fact that, oh, I don't have headaches, I just have normal headaches. Or you say, well, how often do you have a headache? Oh, I get a bad headache. No, I get a bad headache maybe once a month. All right, so you get a headache once a month. You have, any other pains? Oh, I get my normal headaches. I get those almost every day. It's like, what's a normal headache? there is no such thing as a normal headache. If you have a symptom, if you have head pain, there's a reason for it. Now, it may not be, I mean, all headaches are not caused by temporomandibular joint problems. There are multiple causes for headaches, admittedly. But we know by experience, by study, by independent university study, that a huge number of, quote, migraine headaches are actually caused by inflammation within the temporomandibular joint, TMD headaches, and bad headaches, very bad headaches, very frequent headaches. But and there is some interest on my part, because the neurologists and the scientists, academicians who actually study headaches, do write up papers on headaches, migraines. First thing that they admit fully that they don't know what causes migraines. They can describe them. They know it's associated with vascular tree. Actually, the most common description of a migraine headache is trigeminal vascular. I won't go too deeply into that. But I am questioning whether the concept of a migraine, it's just a word, it's a descriptive word that holds a lot of emotion with most people, whether actually there is such a thing as a migraine headache, and that if not all, a good number, maybe the majority of the thing that everybody calls migraine is directly caused by inflammation within the temporomandibular joint and the neurological sympathetic response associated with that inflammation on the nerves and muscles of the face and beyond, of the head and neck and face and beyond. But the point is that frequently, very, very frequently, we see patients who have seen their neurologist, have seen their PCP, they're on medication for migraine headaches, and sometimes for 20 years. I mean, it's not uncommon. It is totally not uncommon for me to do a history on a patient, and they've been on migraine medication of one kind or another for 20 years and still having, quote, migraines. And you do your history, you do your physical, you find that temporomandibular joints are hot, everything is in place, they have multiple symptoms. You treat them properly to decrease the inflammation within the temporomandibular joint by unloading the joint, and, quote, magically, their migraines don't occur anymore. And that is common around here. So, you know, the physicians who treat migraines, and and the patient keeps coming back, and they try one medication and next medication, and both the patient and the physician eventually come up with the conclusion that nothing can be done about it. I mean, they try this, they try that, and we see that so often. That's why we see, I mean, the majority of our patients who come in to see us nowadays have 10 to 40 years of symptoms before they ever hit the door here. And they have seen between, I asked a patient yesterday this question: how many doctors have you seen for these symptoms? And her answer yesterday was six of various kinds. I have heard, I take that back, it wasn't six, it was 30 doctors over 6 years. Excuse me, it's 30 doctors over 6 years. The highest number I've ever heard a patient swear to me was 150 doctors over 20 years. She swore to it that was true. She didn't make it up. That is evidence in itself that the patients are set on a circular route between doctor, and whether it's inferred or stated by the doctor or concluded by the patient that nothing can be done about this. I'm just going around from doctor to doctor to doctor. They're rolling their eyes. Nothing can be done about that. But migraine needs to be investigated greatly. And what percentage of, quote, migraine headaches that are diagnosed prior as a migraine headache, treated as a migraine headache, actually are caused by TMD. And we need to do that study. It's an easy study. Next one on the list is Meniere's disease. Now, Meniere's disease is tinnitus, subjective hearing loss, and vertigo. when patients hit the ENT doctor door, and if patients have one of those three symptoms, I can promise you that if they go to a convenient care clinic or a PCP or anyone else, eventually they're going to be referred, most likely quickly referred to an ear, nose, and throat doctor. The ENT doctor is going to send the patient to their audiologist, check their hearing, and do several other studies, spending several $1,000s, probably an MRI or a CT scan, several other things, looking at those particular symptoms, which is tinnitus, subjective hearing loss, and vertigo, and will not find anything positive, will not come up with anything that they can look at, that they can see, nothing objective that they can measure, at which point they will say, well, you have Meniere's disease. At which point the patient says, oh, good, we know what it is. What can be done about it? At that point, the ENT doctor is going to roll his eyes and say, you know, I'm really sorry, but we don't have a solution for Meniere's disease, which is, by definition, tinnitus, subjective hearing loss, and vertigo, one or more of those three symptoms. And then both the doctor and the patient's opinion is, well, nothing can be done about it. When actually, and again, enlightened ENT doctors in our neighborhood push on the joint, listen for other symptoms that may be there, and conclude, well, this is likely TMD. Go see TMJ Services, Dr. Urbanek and Dr. Urbina. We see more and more of that, but in the general consensus, certainly outside of our arena of operation here in Nashville and Middle Tennessee, Meniere's disease and the ENT doctors conclude nothing can be done about it. Nothing can be done about it. Another, we already talked about the next one, which is the consistent litany list and line of patients who show up here with 20 or 30 years of symptoms that have just gone between doctor and doctor and doctor and doctor. And everyone concludes, including the patient, after failed attempts, recommending this, doing this medication, this service, that nothing can be done about it. Significant limitation in dental schools about TMD. In fact, I think there are around 100 dental schools in the country right now, and I only know of 2 that actually spend any, I won't say significant time, let's just say any time, in actually focusing on the temporomandibular joint disease. They may talk about it a little bit in their oral medicine course, or whatever it would be called in your dental school, oral medicine, where they, see patients with TMD, at which point more than likely they're going to end up with a night guard. It's a circular thing, but the point is that because, and I think it is because the consensus is nothing can be done about it, the dental schools don't want to spend any time on it. I mean, that's evidence right there. The dental schools don't want to spend any time on something that they know there isn't any significant solution for. If they, they know there's a solution for decay, they know there's a solution for impacted wisdom teeth. They know there's a solution for, an infected pulp, and they spend a lot of time teaching doctors, future doctors, how to treat those things. And they spend no time, none at all, on actually teaching young doctors, young dentists, how to treat TMD. That's evidence that the consensus is nothing can be done about it. And then when the patient does end up in, and this is what I'm not going to avoid talking about, but there are dentists out there who do focus on the temporomandibular joint. Whether it's limited completely or just focused on treatment of temporomandibular joint, they focus on not so much treatment, but they focus on the diagnosis, and they spend an inordinate amount of time on asking literally pages and pages of questions on the patient, and then ordering or obtaining complicated X-ray examinations, MRI, CT scans, doing electromyography on the problem to enhance their diagnosis. And then again, whether this is be an independent doctor, or now I'm aware of a few dental schools, especially oral surgery programs, that are kind of focusing on the surgical aspects of this, but they order an inordinate amount of studies and spend little to no time explaining to the patient what's going on and simplifying this to really what's happening. And then if there is a treatment, it is usually long-term, complicated, and involves total reconstruction of their dentition or surgical on the temporomandibular joint. And it just, and being an oral and maxillofacial surgeon myself, and my story is very out there and already discussed in detail why I quit doing temporomandibular joint surgery and how this all came about, and focusing on trying to figure out what is going on. And it ended up with a non-surgical device and understanding how inflammation within the temporomandibular joint actually is the cause of all these symptoms directly. And whether you have a magic wand or whether you just unload the joint sufficiently over a long period of time to decrease that inflammation, it is successful. So what I'm trying to say is practitioners who do try to treat the temporomandibular joint spend an inordinate amount of time talking about or studying or looking at the symptoms rather than the cause. Well, you don't have to be a rocket scientist to know, well, you can treat symptoms, but you're a long way from actually solving the problem if you don't solve the cause. So I made my point. I hope there is this consensus out there, nothing can be done about it, and that is not factual. That is not the truth. You can do something about it. You can do something about it. Now, whether or not you want to, believe me, that's fine. Go out there and start doing your own studies, do your own examination, decrease the inflammation within the temporomandibular joint, however you want to do it. We have an easy way to do it, the Urbanek Device and Protocol. You unload the joint, this protocol goes with it. Disclude the posterior teeth carefully over, you can't go too far. You don't do it 24/7 for too long, but you start out 24/7, then you go to nighttime. We find the 2 months 24/7 does not super erupt the posterior teeth, and adults have to be really careful with adolescents. And we do, and we haven't had any significant problems. Mother is warned that teeth can move fast in a 13-year-old. Teeth can move very fast, but it works the same way. Get them out of pain. They're growing. Teeth are moving. They're going to move. Jaw's going to grow. Teeth are going to move. But we get them out of pain. We get them even in 12-year-old, 13-year-old I've treated successfully. You have to be careful because teeth do move fast in a youngster. So something can be done about it. And I ask you to look for yourself. You don't have to believe me. I'm not trying to convince you. I'm giving you data. Look for yourself. I'm telling you where to look, though. Just like, I did a short presentation at this meeting to the National Academies of Science, Engineering, and Medicine about 2 years ago. It's on YouTube. If you haven't seen it and you can't find it, we can send it to you, send you the link. And this is the volume that came from that consensus study. This is the consensus report, Temporomandibular Joint Disorders, Priorities for Research and Care. And I gave I think it was 7 minutes, I believe, that I presented and basically said, this is what I find. This is what we find of over 3,000 patients. This is where to look. It's all about inflammation. None of that of what I said is covered in here. None. It's real simple, though. hopefully somewhere along the line, people who are at the conference or people who look into this problem in the future will take my advice and look at inflammation and how it affects all these symptoms within the temporomandibular joint. Those of you who'd like to share what you know, or would like to comment or like to criticize, I can be reached at Tony@tmjservices.net. My Director of Marketing and Education can be reached at Naomi@tmjservices.net. If you'd like to join our growing network of doctors who provide our services through using our licensed, patented, FDA cleared and approved device for the treatment of TMD, you're welcome to contact us. You can look at our website at www.tmjservices.net. Until next time, I invite you to peruse the other 82, or I think we're on 80, I'm not sure, 82. Nope, sorry. This is the 87th episode of TMJ Services, 87th episode of TMD Demystified. I invite you to look at many of the other episodes I have explaining the whole process in many different ways, different method, point of views, all coming to the same conclusion and describing the problem in detail, my experience over 46 years as an oral maxillofacial surgeon, 12 years treating it exclusively non-surgically. It's all here, spelled out hopefully extremely well. At least I think it is, because I did it. Those aspects of TMD. So for today, I look forward to the next time I can speak with you. I appreciate your attention. I'm Tony Urbanek, and this is TMD Demystified.